You're about to listen to Julie in Genderland. The whole series is available to download now, wherever you get your podcasts. Please listen, like, and share. My name's Julie Bindle. I'm a feminist. For 40 years, I've been campaigning on the issue of men's violence against women and girls. Now, a new front in that battle has opened up in the form of extreme transgender ideology, which says anyone can change sex, and men are women if they say so. And somewhere along the line, children have been caught up in this insanity. In this podcast series, I'm talking to some of the handful of brave individuals who stood up to this nonsense from the start.
Generations of children were seriously neglected and damaged. This is a complete NHS scandal, and we will look back on this in years to come with incredulity and horror about how this could have happened.
The minority of those children who were referred to endocrinology and then prescribed puberty blockers and or hormones were non-verbal, were living in care, were being groomed and having sex with middle-aged men, were being raped by a family member. So I don't want to be a scaremonger, but I think something did go very wrong.
Welcome to Julie in Genderland. In this episode, I'm speaking to two people who have shown outstanding professional courage. David Bell worked for the Trust, which ran England's Gender Identity Service for Children, GIDS, and Hannah Barnes is Associate Editor at the New Statesman. Hannah used to work for the BBC's Newsnight programme. In 2018, a proposed change to a controversial law caught her attention.
It was at the time when everyone was talking about the Gender Recognition Act and potential changes to that. So I was really interested in that, and I edited a special program about that where some of this came in, and it was really towards the end of that year when it was in the Observer and then the Sunday Times that actually these concerns had been raised about GIDS, and there was a report about it. And that report, which was written by David Bell, who was the staff governor at the time, was going to be investigated by the service.
My name is David Bell. I'm a psychoanalyst and retired consultant psychiatrist. I retired from the Tavistock and Portman NHS Foundation Trust in 2021. I'd worked there for 25 years as a consultant psychiatrist and psychoanalyst. Council of Governors is a kind of oversight structure made up of stakeholders. That is, we had oversight of management, and I was the academic and clinical staff representative, and it was in that role that I became involved in the whole GIDS debacle as a result of clinicians coming to talk to me because of their serious concerns.
It was around that time that I just thought, what on earth is going on? Because it became apparent quite quickly that it wasn't just one clinician who had raised these concerns, it was 10. And perhaps at a time when we've just had the inquiry into the infected blood scandal, we might be forgiven for thinking that whistleblowers come along all the time, but they don't. And in fact, it's quite rare. And to have 10 in one relatively small service, I thought was just extraordinary.
The report was sent to senior management in 2018. It was also sent to the Council of Governors, but senior management tried to prevent me from sending it to the Council of Governors and threatened me. And I took my own legal advice at that point, and was clear that I not only could send it to the Council of Governors, I had an obligation to do so. And that was part of a process of them trying to suppress this important information and serious concerns about children and adolescents.
I just decided to look at it really and started making phone calls, and just out of curiosity. I had no preconceived ideas on the topic whatsoever. I spoke with lots of people, including Michael Biggs, who was at Oxford, and he had got hold of the original documentation, a lot of it anyway, relating to a study that GIDS had started with University College London hospitals looking at the impact of blocking puberty on younger children. And then I met my first clinician, if you like, which was Dr. Anna Hutchinson. I went to her private practice. I was late, which I was mortified about, but my train had actually broken down. And then the very next day was a meeting in the House of Lords, which I also went to, where Anna was at. Dr. David Bell was there, although not really speaking. Marcus Evans was there. He'd already come out in the press by that point. And then Sue Evans, who was Marcus's wife, but was there on the side as well. And we got to this extraordinary point in the meeting where it transpired that the head of communications at the time for the Tavistock, Lord Thomas, had been sitting at the back. And you'll know that these committee rooms in the House of Commons and the House of Lords, they're stuffy and it was packed. And so the participants were sitting around the horseshoe, as that's how they sit, so you can see everybody. And Lord Thomas was in the corner at the back of the room, and she objected to something that Marcus Evans had said about being a conveyor belt, and that people only had a few appointments before they were referred for endocrinology. And then Anna Hutchinson said, well, that's not true, because Law had said, sorry, it got into a real sort of tit for tat. Law had said, oh, minimum 4 appointments. And Anna said, no, that's not true. It's 3. She said, no, it's 4. It's 3. I helped write the service specification. It's 3. And it is 3. It was 3 at the time. And then Sue, who at that point, nobody knew who she was and hadn't spoken, said, well, it was 3 or 4 when I was there, and that was 15 years ago. And the assessments weren't very good then, and I blew the whistle about it. And I just thought, oh my God, what?
Because the service had been captured by an ideological system, that is trans ideology, in particular mermaids, and well, mermaids had some role, and also one of the directors of GIDS was a member of an organization called Gendered Intelligence. And these were trans ideology organizations. The reason I put it like that is because they weren't clinicians. They had no real clinical expertise or knowledge. Instead, they were supporting an ideological agenda, but they had enormous influence on GIDS. And certainly the leads of the service were completely, as I would put it, captured by it. So the fact that they were captured led them to put aside what we would call ordinary clinical management of children and young people, put aside the ordinary ways that we would deal with children who got complicated and difficult problems. And that led to these children, well, in a nutshell, they suffered in 3 ways. Firstly, they suffered because they were given the wrong treatment. Secondly, they were suffered because the multiple problems that they had, which Cass also mentions in her report, were not addressed. And thirdly, they were given to believe that those problems that they did have would be addressed if they went through medical transition. And we know that was false. And the other main problem, I would say, was to do with matters of consent. That is, it was clear that the children and young people were not given the necessary information that they would need. And secondly, they weren't in a psychological state to be able to consent. what child of 11 have an understanding of what it will mean to have an adult sexual body, to be anorgasmic, to be infertile, and so on? The children who I know of, if this was even mentioned, they would just say, I can't speak about that. So there was no proper consent procedure in place. And that, of course, was another major concern. All this was completely bracketed away. GIDS functioned in a way completely abstracted from the ordinary Tavistock traditions. And a number of the clinicians who came to see me, not all, but a number, were gay and lesbian. And 1 or 2 of those, and obviously I'm not going to mention who they were so traumatized that they become psychologically unwell, because they were waking up in the middle of the night thinking of what they'd been involved or complicit without realizing it in doing to children who there was a likelihood, we don't know, but there's a likelihood would become non-gender conforming gay and lesbian adults. And that they felt that there was no interest in the service in sexuality, only in gender. And of course, we know that you don't have to be a great psychoanalyst or psychotherapist or doctor to know that gender and sexuality are totally intertwined. So we also know that we let down very badly all these generations of children who may have turned out to be gay and lesbian. And also the clinicians who were gay and lesbian were very let down, and they were treated as if, one of them described to me how he was called an angry gay man because he was raising concerns about these children.
I remember talking to Sue and I said, what do you mean you blew the whistle on this thing? And I'd had this meeting with Anna the day before, which had blown my mind, really. I mean, it wasn't, she was very, very cautious, understandably, because she didn't know who I was and was not very trusting of journalists at all, which most people aren't. But there was enough there that I just thought, well, something's going on here. And I was talking with Sue and I said, well, what happened? She said, I don't know. I said, there was a report. I said, but I never saw it. I said, well, who did it? So she told me it was a guy called Dr. David Taylor. I said, all right. And I can't remember what day of the week it was, but the next day or the following week at work, I put in a Freedom of Information request for this report. No, originally I contacted Dr. Taylor, who was very nice. He said, I don't have it. He said, I wish I did, but I don't. So no one seemed to have this report. So I stick in that FOI request. And in the meantime, Deborah Cohen joins me on the story because of her medical background. And that was what we wanted to do anyway. It's part of the NHS. It's a specialist service. And we put that film out. We actually, naively, I don't want to speak for Deb, but I was pretty naive about it, that I just thought, well, that's the least contentious bit to go for, is the evidence base. Because if we get that right, then we can explore some of the other things. Yeah, quickly that became not evident that wasn't the case, that anything you did was difficult. And we had the longest writer reply I think I've ever written to the team at the Tavistock. They didn't want to take part. And then we had a back and forth as well, which is quite strange. I don't think I've done that with writer replies. And during the course of doing that, we weren't the first actually, but partly we just did it in so much depth and found out new things. So I think inadvertently we came across information that, well, the Tavistock gave us certain things that weren't in the public domain. So for example, we found out that actually this had been rolled out, which is one of the most shocking things to the story, prior to, as policy in 2014. I don't think we really knew that at that point. We found out that actually at the time they were applying for permission to do that study, the Dutch had already reported, albeit online, but the researchers were in touch with the Dutch team quite often, that every single one of the children that started puberty blockers went on to cross-sex hormones. So part of our piece became, well, has all the relevant information been shared? Because certainly on the written information, neither children nor parents were told that. And they did know it at the time. And subsequently, Professor Russell Viner, who led that study, confirmed to me that they did know it. And he says he raised it verbally with all those children. But it wasn't on the written information.
Tell us, if you will, about the Dutch study. Just give us the information.
So the Dutch study is a really classic example of what's happened in this area of healthcare, where there's a piece of research. It's not that strong in and of itself. The paper itself makes quite cautious claims, and then it becomes amplified over time. And no one actually ever goes back to what the original paper said. So this was a study of 70 children who were given puberty blockers between the ages of 12 and 15. And to be on that study, you had to meet certain conditions. So you had to have had this gender incongruence since early childhood. It had to have been persistent for a number of years, and it had to have got, the distress you felt from that had to have got worse as at the onset of puberty. You had to have a stable home environment, because it's all gender clinicians will admit, I think, and trans people and those who don't transition or regret transition will all say it's not easy, even for those for whom they have a successful outcome. And you had to be free of any other major psychological problems. So it provided you met those criteria, you could go on the blocker. So the Dutch report they had started rolling this out in around the year 2000 as a pathway, if you like. It was called the Dutch Protocol. They reported in 2010, and it was published in a journal in 2011, but online in 2010, that all 70 of these children had gone on to the next stage of the pathway, which was cross-sex hormones, synthetic hormones. So for those born male, that would be estrogen, testosterone for the females. And they reported after being on the puberty blocker, their mental health had kind of improved. But they were actually quite cautious, the Dutch. They said these are early, cautious findings that for a very select group of people, this might be a good treatment. I mean, I'm paraphrasing here, because they didn't find improvements across the spectrum. They didn't find any reduction in gender dysphoria, and there were some sex differences as well. So some of the females, their body image and things like that actually got worse. And there were reductions in things like anger either or anxiety. So it really wasn't that persuasive a picture anyway. But that's what it then turned into. Puberty blockers have a massive boost to mental health. Then fast forward a few years. By this point, GIDS have started their study. We get to 2014, and the Dutch publish an update on these 70 children who by now have become old enough to be eligible for the next stage of that pathway, which is surgery. And at that time in the Netherlands, you had to have genital surgery in order to be able to legally change your sex. That's no longer the case. But by now, that group of 70 is 55. And the Dutch team simply say, well, that doesn't matter because they were all matched at the beginning and they're all roughly on par. But when you look at what's happened to those 15, it clearly does matter. One of them has died, and they died absolutely as a consequence of sex reassignment or gender affirming surgery. This was a male to female surgery, and whilst trying to make a vaginoplasty, and this male had been blocked early in puberty, so they had to use a technique which used part of the colon. They died from an infection. 3 were not allowed to have surgery because they were morbidly obese. And interestingly, prior to starting with the puberty blockers, none of them had any health difficulties. And there are some other quite interesting health difficulties within this group. And we don't know if any of them just chose to not continue with the transition or anything like that. So we have immediately 20 odd % are gone. Then of the 55, we only have full data for around 40. I can't remember the precise number off the top of my head. And for the major measure, which is resolvement of gender dysphoria, it's fewer than 40. So you've got just over half of the original group. And the major outcome is gender dysphoria completely relieved, functioning at comparative levels to peers who haven't transitioned. Now, years later, some very clever researchers identified something that had happened when they measured gender dysphoria in those young people at that point. Now, when they'd measured the level of distress these children were feeling before they took puberty blockers, they used a survey which coincided with their biological sex. So if I'm taking it as a girl, it says things like, I hate having periods, I hate breasts, I hate things that are obviously feminine. What they did when they reissued the survey is they didn't give the now trans men, the biological females, that survey. They gave them the one for males. So they gave them the ones for their transitioned gender. So instead, I now answer a survey which says, I hate having an erection. My penis makes me feel sick. Things like this. I hate being a boy. Now, of course, some of those will be completely redundant because they won't be having erections because they don't have, I don't think any of them had a phalloplasty and whatever. But also, of course, they're not going to answer yes to I hate being a boy, because being a boy and being perceived as a boy is the precise thing they want. So the scores on these scales, the Dutch researchers go, aha, the gender dysphoria is completely resolved. The researchers who discovered this only in the last few years said, well, there's no way of telling whether the resolution of the gender dysphoria is entirely because the scales were switched. And there were other problems with the study as well. in the Netherlands, all the children undergoing the medical pathway were at the same time receiving talking therapy, psychotherapy. So we can't control for whether actually it was that was making them feel better in some cases. And obviously we have this loss to follow up, and it's really not robust. And really it's those two studies, it's the same study really, the same cohort, that is the sole and only basis for the medical transitioning of children in the Western world. And that's it. And the only attempt to replicate that first stage of the study, the impact of puberty blockers, failed to do that. So that was the GID study that we were talking about. And in fact, it found that there was no change in psychological function. And in fact, if you looked at the individual trajectories of those kids, which researchers later did, Susan McPherson and David Friedman, you found, in fact, about a third stayed the same, no change, about a third improved, and about a third got worse. So 2/3 effectively, you're no better off. With the big caveat in all of this, to be a geek, we can't say in either the Dutch studies or the British one that it was down to the blockers, because they didn't control for anything. There was no kind of control group. Right. So it's pretty useless, really. Right. It's pretty useless. And then what happens as we go through the 2000s, the Dutch have started this protocol. A paper is released at a pharmaceutical convention sponsored by Ferring, who make the particular puberty blocker drug that the Dutch are using. And they release to the world the really detailed dosage of what they're using in the Dutch protocol. And other clinics, Belgium, begin to do this. There's a clinic in Boston that opens that starts doing this. And there's increasing pressure on GIDs to do it as well. And not just from trans support groups and trans adults who say, I wish I'd had this when I was a child, it would have saved me lots of grief. But also there was quite a lot of pressure coming from the medical community. So endocrinologists were saying that this appears to be the gold standard of treatment. I'm not sure how they ever could have said that, given the samples were so small, but this appears to be beneficial. If we proceed cautiously, there's no right reason we shouldn't be doing it. And ethicists certainly made the argument that it was unethical not to give this treatment. We have to remember that at that time it was a very, very tiny number of children who had to be in significant distress and meet these conditions. So that's what happened. And then they said, well, we'll do our own trial as well. So I think to begin with, it was absolutely well-intentioned, because they had these children sitting in front of them who had felt this way the vast majority of their lives. They didn't feel they were who they were meant to be. They identified as another gender, and they were very, very distressed about it. And here we had potentially an intervention that could help in strict circumstances. What went wrong is, having said we need to find out more and do a study, they didn't wait for any of the data from that study to come back before rolling out this as routine clinical practice. And not only rolling it out as routine clinical practice and not following up any of those people or collecting data, they rolled it out to a group of people who frankly didn't meet any of the criteria of the Dutch study. So GIDs were referring children and teenagers for puberty blockers who had severe mental health difficulties, other conditions, who were in frankly chaotic family circumstances, were living in care, were living in hostels. I mean, people may have heard of the case of Kira Bell, who regretted her transition, having been through GIDs. Kira was living in temporary accommodation on her own when she was given testosterone. They were also prescribing, they referred to the endocrinologists at UCLH who prescribed, but they were referring people who identified as non-binary. Now, non-binary didn't exist in the literature. There's no mention of it. And the Dutch would only allow puberty blockers for those who had a cross-sex identification from this very young age. So they started applying what was only ever a weak evidence base to a completely different cohort of people for whom it was never designed and actually never would have been allowed to have this intervention. And that's what's extraordinary. And then when they did get data back, which did not confirm that this was benefiting children, they didn't stop, or they didn't pause for thought in any way.
the children who go on puberty blockers, when it started, they almost all came off anyway. That's still wrong, because puberty, a child's body isn't like a video machine that you can press pause, leave it for 2 years and restart. It isn't like that. The mind, the body, the psychology, the social situation are all ready for puberty. But nevertheless, most did come off. More recently, over the last few years before we stopped, 98% went on to opposite sex hormones. 98%. So starting them on puberty blockers was de facto starting them on a medical pathway to opposite sex hormones. Now, in terms of the damage, one of the most disturbing parts is what I call the Orwellian newspeak. That is, talking about top surgery and bottom surgery, because it sounds benign. It sounds like a minor plastic surgery, like a nose job or something. You were talking about double mastectomy, removal of pelvic organs, so removal of sexual organs. We're talking about the building of a fabricated sexual organ, such as a vagina or a penis. These are major, major surgeries with real risks of serious long-term damage and harm, such as incontinence, for example, such as vaginal atrophy, needing to have a hysterectomy later because of the potential damage being done to the uterus through not having its normal hormonal environment. Starting on a pathway of having these medical and surgical interventions also means that you're becoming, in a sense, a patient for the rest of your life. There'll need to be follow-ups. There may be further complications. We're also beginning to become aware of cardiovascular complications. You need quite a long-term follow-up to find these things out. There are other, and I don't have the whole list in mind, but certainly there's quite a growing list of serious medical and surgical complications, both immediate ones, like what I just mentioned, like incontinence and so on, but also and chronic cystitis, but also other kinds of longer-term medical consequences, such as cardiovascular consequences, that we're still finding out about. There's some that we know, some that we don't know. There's a big unknown and reasonable reasons to be very concerned. So you can't treat this. It's being treated in such a light way, as if it's just a bit of top and bottom surgery, and it isn't. It's very, very major surgery with potential serious long-term consequences. Cass has to be properly judicious about what she says. And in her report, she's really gone very far, further than, quite honestly, I thought she would be able to. But she can't say certain things, and I don't know whether she believes them or not. But there are certain things I can say that she certainly couldn't, even if she did believe them.
Such as?
These children were seriously neglected and damaged. Generations of children were seriously neglected and damaged. This is a complete NHS scandal, and we will look back on this in years to come with incredulity and horror about how this could have happened.
Did trans activists play a role in the actions and decisions of these clinicians, or at least senior management?
I think it's a yes and no and a bit more to it. So yes, trans activists and some of the support groups were definitely influential. They were influential in bringing about early intervention, so this earlier blocking of puberty. But they weren't solely responsible for that. They were influential in that they had the ear of not only the director of GIDS, firstly the founder of the service, Domenico DeCeli, and then later Polly Carmichael from 2009, but they had the ear of the chief executive and the chair as well. I mean, there's a paper trail that shows that the groups that were in contact, and it's not just mermaids. People talk about mermaids, but there's Jaras, who were much more influential in the very early years, actually. And then in later years, gendered intelligence as well. You had Baroness Barker, the Lib Dem peer, who acted as it's very strange. She seems to act from emails as a conduit between the groups and Paul Burstow, who was chair, also a Liberal Democrat, and the chief executive then, Paul Jenkins. And they have these meetings. So they had the ear of the senior people at the Tavistock Trust. They were certainly putting on pressure. I mean, Mermaids, Bernadette Wren, who was effectively the number 2 at GIDS, I suppose, for a decade, told Parliament that, you know, Mermaids were constantly putting on pressure for the service to allow cross-sex hormones at younger ages, and they would lobby for, and to have fewer assessment sessions, to have fewer questions asked, to have a fast track. Now, not all of these things happen, so that's why I say yes and no. I mean, certainly every clinician every clinician I spoke to, which was dozens, regardless of how they felt about the service, actually said we were always aware of mermaids. Not that like there was a presence there, not that they were physically in the room, although they did accompany some families to their appointments and sit in the waiting rooms, but they were there at the back of clinicians' minds. And they knew that if they didn't do certain things, then there would be complaints. And there were. And Susie Green, I'm told, would request that admissions be swapped if a family weren't being referred fast enough. I mean, Anastasis Spiliadis says that happened to him, and others have said that too. Whether you can actually pinpoint that they changed individual clinical decisions, I think is much harder. Obviously, the Tavistock deny that, and so does Susie Green of Mermaids. But they were certainly influential, and I think they had this much more subtle influence where they stopped. It was fear of and grief, if you like getting a bit of flack, that meant that GIDS didn't change direction when they should and could have, and they didn't commit really important things to paper and codify it because there was this fear of the reaction. And there are a couple of examples of that which are really quite astonishing, that it's very difficult to explain why they wouldn't have done it.
And what about life after the Cass report? Was there anything in Cass which surprised you?
The thing that shocked me the most was the refusal of the adult services, the adult gender identity clinics, to cooperate with the review team and provide any of the data that they'd asked for, bearing in mind there'd been a change of the law in order to help get that research. I found that astonishing, because assuming that the men and women and non-binary people who work in gender clinics want what's very best for their patients, I cannot comprehend why you would not want a study to be done which shows the outcomes. And as Dr. Cass said to me herself, if you had faith in what you were doing, why wouldn't you want to shout that from the rooftops? Now, the excuses that the various clinics put forward didn't really make sense, given that the research had gone through a really strict, as you'd expect, and rightly so, really strict ethical approval process over a year, and it had been approved. None of the researchers from the University of York would have had access to any patient identifying information. This kind of research is done all the time across the NHS, Dr. Cass told me. There were no, so all these reasons put forward were sort of spurious and dealt with. And even the issue of resource, NHS England had promised to provide any extra resource that was needed in order to get this data. So that was the most appalling thing that stood out for me. And related to that, there's a tiny bit in there which says that the Tavistock and Portman NHS Foundation Trust, which obviously ran GIDS, but it also is responsible for the Charing Cross Identity Clinic, the adult clinic, the largest in England, well, the UK, refused Dr. Cass and her team an audit that had been undertaken of those who had detransitioned. They refused to let her see that, which one psychiatrist had compiled. And again, it's when I interviewed Dr. Cass for the New Statesman in the middle of May, she made the point, and it makes perfect sense to me as well. It's something I've said. Understanding why a treatment hasn't worked for people, and perhaps any commonalities there, is just as important as understanding if it does work. And you're going to benefit both groups the more information you have. So it's staggering. And then, as the geek that I am about this, one thing that stood out for me too was another incident where GIDS had been operating what you might call off-spec. So the service specification is this document that generally was the guidelines for what GIDS was doing and what the endocrinologists at Leeds and UCLH were doing. It was always the case there, and people disagreed with this, but it was the case that you had, in order for a young person to go onto hormones, the earliest you could do that was around 16, which came to be interpreted as 15 and 9 months. But the only way you could do that was to have been on puberty blockers first. So you couldn't, even at 17, while under the care of GIDS, you couldn't go straight onto hormones. If you knew where to look for it, and you're, a geek like me, it confirmed in the Cass report, and indeed Dr. Cass said that this was the case, that in fact they were putting 16-year-olds straight onto hormones without the blockers in some cases. And it just made me question, well, now there are arguments for that, to be fair, because what's the point of putting a 15-year-old on a puberty blocker? You're not blocking puberty, particularly in girls. But the point is that should have been done, so Dr. Cass argued, in a research setting. And really, it should have been public knowledge that they were doing that. And it wasn't. It never has been.
In August 2024, the NHS gave details of a clinical trial of puberty blockers, which is due to start early next year. To have such a trial is controversial.
I don't think there should ever be a clinical trial of puberty blockers. And I've thought very carefully about this and discussed it with a colleague who's an ethical expert. And if you think about it, the reason is quite simple. You do a clinical trial, like, first of all, doing a clinical trial on anyone, there has to be quite a high threshold that this is a drug that is reasonable hope will be successful, in which other treatments aren't. That's the reason for doing a trial. Or it's much better than other treatments, and there's reasons to believe that. That's the first thing. Secondly, there's an even bigger threshold in having any trial of a drug in children. Now, just to give you the comparison, just suppose we had a new drug for leukemia in children. And suppose that this kind of leukemia, let's just say 30 to 40% died. And there was a suggestion that this drug might have a huge effect. Then there'd be, the beginning of the ethics, there'd be other things to go through for clinical trial. But with puberty blockers, there is no evidence. There's nothing to base the belief on that they might do good. Nothing at all. The little bits of evidence they have, which isn't good, but it's something, is that they did harm. That was the trial at the Tavistock, which was covered up for quite a while. Secondly, when I say we have data, all data is very poor. But, I mean, very poor in some of it's quite a long time ago. Some of it, there's been no adequate follow-ups of any of the children. That was one of the big scandals, that none of these kids were followed up, so we don't know what happened to them. But even saying that, there's reasonable reason to believe that the large majority of children who present with gender dysphoria or gender distress or desist will change their minds. So if that's true, if they'll desist, if the majority will desist, if supported and treated in a different way with a proper kind of psychological intervention and without the invasion of trans ideology into the treatment setting, then how can you justify putting children on a trial when a lot of them are going to desist anyway? I can understand why some people may feel the need to say this, for example, politicians, because it sounds as if you're being reasonable. But when you go into it, I cannot see how there could be an ethical justification for doing a clinical trial.
There are arguments, aren't there, that it's unethical from both ends of the spectrum, if you like. So from the trans side, if you want to put it that way, there's an argument it's unethical because you're coercing someone to participate in research to get a medical treatment. I personally don't find that a persuasive argument. And again, I'm basing that on conversations with doctors and people who design research trials. That happens all the time in medicine, that in order to access a treatment for which we don't have robust data, whether it's safe or not, you have to go in a research trial. That happens with cancer drugs. So I can sort of understand why they might think that, given they have been previously available. But the idea now is to bring this area of healthcare back in line with good, proper evidence-based medicine. So, and on the other side, you've got the argument that it's unethical to put more children on puberty blockers when we know that they're harmful. Now, it's really tricky because, first of all, the NICE evidence reviews of puberty blockers said, and actually what the systematic evidence review undertaken by the University of York said, was that we don't know either way because the studies are of low quality. So there's no robust evidence that they're safe and beneficial, but actually there isn't robust evidence that they're harmful either because the studies themselves are not very well designed. We do know for a fact it's not very good for your bone health while you are on them. But we also know that if you go on hormones, whether that's your own biological ones or synthetic, that bone density does increase again. But we don't know whether it would ever get to the peak. We just don't know the answer to that question. I tried to draw Hilary Cass on this, and she's a very sensible woman. But she said that there are some things that we could find out very quickly that wouldn't take, a decade or what have you. And that would be the effect that puberty blockers have on cognitive function, on your brain development, I suppose. And she said you could find that out in a year, 2 years. Now, there's definitely a question there, isn't it? Is that a price worth paying to potentially run a trial and find out, oh yes, it does impact cognitive function, and then those young people who've taken it are impaired for the rest of their lives? Now, I guess if all those risks are put to the children and their parents, it might be a risk that they're willing to take. I don't know. It's very difficult. I can see how it's going to be very hard. And who knows, they may not be able to design a trial that will get ethical approval. I think one of the difficulties here is there isn't really agreement on what the purpose of the blocker is. So when you take a drug, say there's a new leukemia drug for children, it's very obvious what you're trying to achieve by it. You're trying to rid the body of the cancer. And the consequence of not doing that is potentially death. With puberty blockers used in this context, there isn't agreement on what would be a good outcome. I say that because I've asked lots of clinicians, even those who still work in gender clinics, what is the purpose? Now, is it to reduce distress? Is it to reduce gender dysphoria? Is it to simply block puberty? Or is it simply for males to literally prevent a puberty so that passing for you in adult life is easier and you have fewer surgeries? Now, they're very different things, actually. And I don't think there's agreement on what a successful outcome is. So it's very hard to design a trial. And I think it's different. So we know from the Cass report that actually the argument that if children and young people don't have puberty blockers, that they will take their own lives, we know that isn't borne out by the facts, thank God. So again, it's not like a cancer drug or an epilepsy drug where the consequence of not taking it is your physical health is, life-changingly impacted, and it might even result in death. I mean, I'm sure there will be people in the trans community who disagree with me there, but I just think it's just not clear cut, is it? It's compared to other trials.
Having talked to so many people over the years and amassing so much evidence and opinions from pretty much every corner of the debate, what is the future for gender distressed young people now, post-Cass, and with everything that we know?
I think in the immediate term, it's pretty dire, because I think the model of care that's come out of Cass is really positive. But she is under no illusions that things are going to change quickly, because they can't. I mean, apart from anything else, you've got a waiting list of 5,000-6,000 children and young people, all of whom are distressed. I think there's this cocktail of difficulties. So on the one hand, you've got these young people on this waiting list who are gender distressed, and they're also distressed that a treatment that frankly they've been told is life-saving and the only treatment available to them, and is this cure to their distress, has been taken away. And we as a society en masse, not everybody obviously, have kind of lied to them. Like, what's so damning really is that Dr. Cass has said for nearly a decade, we've given these drugs to gender distressed children without any evidence that it's helped them. It's quite powerful. But they've been led to believe it's the answer. So they're really distressed about that. And I think building trust back in the NHS is really difficult for some of those children. You've also got this major problem that they can't recruit to these new services. So they didn't want the people working in GIDS, and certainly not the people working at GIDS at the time it was closed, and they didn't take any of them. But as you all know, as anyone who's covered this area knows, there's so much scrutiny, there's so much toxicity that the clinicians that they want to work there are not applying. And Hilary Cass has said, sort of pleaded, I suppose, with careful and thoughtful clinicians working across other children's services, saying, look, you know these kids, there's nothing different about these children. They have the same hopes and dreams. And actually, you know, you might work in an eating disorder service, you might work in CAMS, you might work in an autism service, and some of those kids you're seeing will have gender distress as well. So this is not new to you, and you've got the skills. There's nothing. But I guess, and I would take some responsibility for this, there's a lot of scrutiny on those new services. I can well understand why people wouldn't want to work in them. So we've got this really difficult situation.
Should we have gender clinics? Should they exist?
Well, I think in a way that's a practical question. It is odd that we ever had a national gender clinic. Gender should never be treated as a separate thing from who you are as a person. In an ideal world, there would be no gender clinics, because people presenting with gender distress who have multiple problems, which, you know, Cass called diagnostic overshadowing. So all these other problems that they have should be looked after within a CAM service. So you wouldn't need a gender clinic. It would be part of the CAM service, just like a child may be upset about their sexual identity, or disturbed about various things happening to them as they grow up, or they may be depressed or suffer from autism or various other kinds of problems. That would all be part of the ordinary work of a CAMS clinic, and that's the way it should be. But here's two big buts. First big but is this, is that CAMS clinics have been on their knees since long before COVID and before this whole gender problem. That is, if you're a child with depression, you can wait 1.5 years, 2 years to be seen in a CAMS clinic. So the CAMS services do not have the resources to look after children with any problems. So what has been happening, and what was happening when the GID service existed, is that if you have multiple problems as a kid, say a family problem, maybe there's been a bereavement, maybe there's some issues to do with autism, maybe there's some issues to do with depression, and you mention gender, they would say, great, off you go to the gender clinic, because they got all the specialist resources there and they'll look after you at the Tavistock. Of course, they're wrong, because they didn't look after them. They gave them the wrong treatment instead and didn't look after the other problems that they had. But you can sympathize with the CAM services, because they oh, good, we can send the child somewhere else. So you need a reform of CAM services with a huge amount of funding. Secondly, we need to do a lot of work in schools, that is ensuring that trans ideological movements do not have access to educating children and teachers in schools, because children are very easily influenced, especially girls are very easily influenced. And when a thing becomes a thing in a school, it spreads quite quickly. So we need to do something about the schools. But to come back to the gender services, we kind of are where we are. So I suspect it's politically impossible not to have some gender services given where we are. So it's a kind of compromise position, as I would see it. I think the way Cass sees it is that we'll have these gender hubs, but the children will be seen by multidisciplinary teams, and there'll be an attempt that many of them will be jointly managed with their local CAMP services. So they won't be. Nevertheless, from my point of view, perhaps it's, I'm freer to say this because I'm not organizing services, but I think that it's still a problem, because if you say to the child and the family, we're sending you to a thing called a gender clinic, then you're setting it up as a gender problem. You're badging it as a gender problem.
I discussed that with Hilary Cass as well, because everything she was saying to me sounded exactly like what Dr. Bell said. Take the gender out of it, treat the young person as a whole. That actually makes much more sense. But her response was, well, you go for an autism diagnosis because you think you've got autism, and in the end you might come out without one because you haven't, but it's still, you need somewhere to go. And so I think I can see that one on both sides. I mean, I think what they're trying to achieve is an adolescent or children and adolescent distress service, and it's got the word gender on it as well, but the focus isn't solely on the gender. But yeah, and I mean, I think Dr. Bell has a point.
When it comes to parents, one proportion of them will be, as you say, trans ideologists. There'll be others who took up that position, and it's difficult for them to change, but maybe they might change if they can be supported and helped, and not to feel too guilty themselves, because to see that they were caught up in something. There are some parents I've heard of who knew that they had a very disturbed child and felt, normally, I would say, of course, terrible about it and very guilty, as any parent does. And then when the child said they were trans and they started learning about trans online and talking to people, they suddenly thought the child isn't disturbed, they're trans. And that was a great relief to them. They felt, I haven't damaged my child, it's just that they're a trans child, they were born in the wrong body. So now I can help them. And once they get into that position, it's a great relief. So then it's very hard to have to give it up and go back to facing the fact that they've got a child who's got quite a good deal of psychological disturbance. But maybe some of those parents could be helped with that. And there'll be others, as I say, who can't be.
I think the parents get a really hard press in this. And I think there's this really black and white narrative that parents are either transphobic and will kick the kids out of the house if they're even the slightest gender non-conforming, or at the other end of the spectrum, they're somehow guilty of Munchausen's by proxy. And it really isn't like that. I mean, I think, you would have a tiny proportion who are like both, but actually from the parents I've spoken to, both of children who have gone on to transition and those who haven't, the vast majority of parents just want to do what's best for their children. And the worst thing in the world is seeing your kids in distress, and they just don't know what to do. They really don't know what to do. And, you live with your children every day. You do know them. The idea that parents don't know anything about their kids, I find quite, as a principle, a bit insulting. Of course, there are parents that harm their children, but thankfully they're in the minority as well. And I think one of the many tragedies in this story has been that parents who didn't know what to do, seen their children in extreme amounts of distress, have sought the help of specialists, of doctors, because that's who we put our trust in, and they've let them down. And in some cases, those doctors didn't know anything. And I'm so in awe of some of the clinicians I've spoken to who say, God, I did terrible work and I feel terrible about it, but we didn't know. I think it's much easier to be forgiving if we're talking about 2014, 15, 16, even 17, because they really didn't know. They were trying to help, and they were only providing the parents with the information that they thought was correct, genuinely. It turned out not to be. And some of those clinicians feel terrible about that. I don't think we can judge them too harshly for that, really. And actually, the mum There's a case study in the book called Jacob, who waived his anonymity actually to do Newsnight with me, who's called M. He still identifies as trans. And his mum Dee said, I don't blame the clinicians. Like, if they didn't know, they didn't know. But what I cannot forgive is that M went through this horrendous time on puberty blockers, 4 years from the age of 12 to 16, really critical years. And that the endocrinologists at UCLH have never followed up with him. They haven't checked his bone health. I mean, they put him on beta blockers and he collapsed to try and slow down how quickly the blocker was going through his body. Because I think people don't understand, this isn't a pill that you take. The puberty blocker is not like a paracetamol. It's an injection. It's major. I think where it's harder to understand is, as we come into the later years, and there was that data that showed this intervention wasn't terribly beneficial to many. And some of these children were really, really struggling.
Do you think that there should be consequences for the key players that have driven this forward and caused the harm of children?
I really don't know. I think it would be helpful if some kind of report could be written whose aim is to try and understand why this happened and how it was allowed to happen, so that we might learn something from it, so that it might not happen again. How terribly easy it was for the ordinary canons of clinical care to be completely put aside and for children to become victims of an ideological movement. So I think we need to learn something from it. I think there's different kinds of people, aren't there? You see, if you take someone like the CEO of the Tavistock, who got things terribly, terribly wrong and tried to silence me and so on. But I actually don't think he was badly intentioned. I think he was ignorant, misinformed, and I got caught up in this and thought it was some great new sort of treatment. Where there are other people who I think are much more malignant, where they were actually using this opportunity to influence children in this way, and who were very captured by trans ideology and had that particular aim. Because one of the things we notice, isn't it, about the whole way that the trans organizations captured, they never did it through debate or discussion or argument. It was through influence. And Stonewall is a fantastic example of that, the way they've managed to have this influence by persuading people to become Stonewall champions. I mean, I think maybe it's more important that some of these things are stopped. No NHS service, no university, no public organization should be a Stonewall champion, given what we now know.
It's impossible to convey just how vulnerable some of those children were. And I don't mean all, and certainly not the majority, but a minority of those children who were referred to endocrinology and then prescribed puberty blockers and or hormones were non-verbal, were living in care, were being groomed and having sex with middle-aged men, were being raped by a family member. And I don't say that to be extreme. And again, I have to stress, it's a minority. But a minority thrived as well. And Dr. Cass says the same thing. So I don't want to be a scaremonger, but I think something did go very wrong here.
You've been listening to Julie in Genderland. The whole series is available to download now, wherever you get your podcasts. Please listen, like, and share.